Hi everyone, today I will talk about my work, the relationship between 2D and 3D sacropelvic measurements. Degenerative disc disease is a major musculoskeletal disorder, often surgically operated using fusion implant devices. The International Spine Study Group has recorded that the success of spinal fusion surgery relies on maintaining the optimal values of sacropelvic parameters. Also, the global sagittal balance is highly correlated with these parameters. Generally, the quantitative measurements of the sacropelvic parameters are usually performed on 2D sagittal or frontal x-rays pre-surgery, but the information obtained from the projection of 2D is very limited compared to the parameters calculated in 3D. Therefore, the aim of this study was to compare the sacropelvic parameters measured in 2D and 3D, and also to understand the correlation between bone shape and sacropelvic parameters. So for my methods, at first, de-identified CT scans from 70 healthy adult participants were collected, out of which 44 were men. And then it was 3D reconstructed using mimics. And then all the bones were fitted and aligned to the template meshes. And then a principal component analysis was performed using an in-house Python library called GAIS2 to understand the bone shape variation. An orthopedic surgeon measured 2D sacropelvic parameters such as anterior pelvic angle, pelvic incidence, sacral table angle, projection angle, femorosacropelvic angle, and crest pubic distance, crest sacrum distance, inlet and outlet distances. So we developed a Python code to find each pelvic and sacrum landmarks necessary to calculate the 2D and 3D angles such as bicoxofemoral midpoint, and then um, the anterior superior iliac spine distances, the superior and inferior pubic symphysis, and then we calculated all the angles automatically from the fitted meshes, and then the comparison between the 2D and 3D calculations were done using t-test. So for my results, we can see that in figure 1, 2, and 3, these are the angles I have mentioned, which is measured by the 2D surgeons in the CT scan slices. And then from the table 1, we found out the relation between R value and the bone variations for combined pelvis and sacrum. We performed the Pearson correlation coefficient test to understand the bone shape variation and if there is any relationship between these 2D sacropelvic parameters and the bone shape. And from our result, we can see that the sacral ala width and the ischium width was negatively correlated with the anterior pelvic angle. So here from figure 1, anterior pelvic angle is the angle which is beta, which is the line joining the midpoint of the sacral endplate and the bicoxofemoral head and the superior margin of the pubic symphysis. And from table 2, we saw the relationship between R value and bone variations for sacrum. And we saw that for sacrum, the sacral plateau width is positively correlated with the pelvic incidence angle. So pelvic incidence angle is a very important angle for surgical planning. It's called as a cornerstone for surgical planning because pelvic incidence angle can predict the ideal individual lumbar lordosis, so the fusion surgery planning doesn't go wrong. And from our result, the pelvic incidence angle is strongly correlated with the sacral plateau width, which means if a patient is having a higher pelvic incidence angle, then the width should be also higher. And the pelvic incidence angle in first figure is alpha, which is formed by the midpoint of the sacral end plate and the bicoxofemoral head. So the 2D measurement performed by the surgeon for sagittal alignment was accurate when compared to the 3D measurements from our study. And we are also developing a finite element model of lumbar vertebrae, pelvis and sacrum before and after surgery to help the surgeons in surgery.